All right, we're live at the Techie Surgeon. Hello, everyone. Thanks for those of you who are starting to trickle in and join. And for those of you who are watching this later, really appreciate you tuning in. This is a Techie Surgeon Substack where we talk about all things clinical AI and health policy. Today, I'm really excited to welcome a value-based care operator and expert to the podcast, the Substack, Sarah Habeeb. Sarah, why don't you do a little bit of an intro to all of us here? Tell us kind of what you do now for Baylor Scott and White, and then from there, maybe I'd love to hear how you got into accountable care and value based care. Oh, for some reason I'm not hearing you. Can you hear me? Okay.
Can you hear me now? I think I
Yes.
have a
Yes.
problem with mine. Okay, sorry, there was an echo on mine. I'm going to shake these headphones. Yeah. Can you hear me?
All right. Yeah. Yeah. We got you.
Okay. Sorry about that. I'm still getting an echo. Are you okay on my audio?
There's a little bit of an echo.
Okay, hold on a second. Beginner's luck. How's that?
No. It happened to me last time.
Okay, I think I've figured it out.
Okay.
I'm not the techie surgeon. Okay, so I'm Sarah Habeeb. I am the system director for Medicare value-based care products at Baylor Scott and White Health. I've been there since 2021, but just a little bit of my backstory. I was pre-med in undergrad, and I went to Texas A&M, started getting my EMT, was going to get my paramedic, and thought, let me just get an intro into the clinical world. And that was not for me. I was like, nope, hard pivot. I don't enjoy being here. I don't enjoy touching patients. So what am I going to do with like this hard science background in undergrad, and what's my next move? So I did my master's in hospital administration also at Texas A&M, and was working full time during grad school at a small rural hospital in College Station, and sort of got a very brief intro to value-based care in grad school. This was like 2014 timeframe where the Medicare Shared Savings Program was pretty new and everyone was just kind of trying to figure out what the heck it was. And I thought it made sense, conceptually, and naively thought this is the future. This is what's going to happen. Everyone's going to move into value-based care. So I just sort of made that strategic move career-wise and picked value-based care and worked my way up through that Common Spirit Hospital. And as I'm sure you all are aware, when you're at a smaller hospital, you just become the jack of all trades and you kind of do everything for that department. So we had commercial Medicare Advantage and traditional Medicare risk contracts. And it was like a three-man team where you do the care management operations and the quality reporting and the risk score education and the data analytics and the regulatory and all that kind of stuff. And so I did that for 4 or 5 years before I got my foot in the door at Baylor Scott and White. And I think, the good thing about value-based care is that the tenets of how to do it don't fundamentally change if you have a 7,000 life MSSP or 120,000 life MSSP. You're all on the same quality measures. You're all looking at utilization. And so my goal, joining Baylor Scott and White at first was like, don't screw this up. They're already a top performer. Don't come in here and just tank their performance. And so luckily that hasn't happened. They've remained
Done very well.
top performer. And my roles evolved a little bit to any CMMI model that comes out that's traditional Medicare, whether or not it's optional or mandatory, what's our stance on it and our performance, and things like access and ASM and team, and just overall what's our strategy, and how do we do that in conjunction with our own health plans, Medicare Advantage product, and then any third party MA risk contracts as well. So I have some peers who have their own Medicare products, and then I am the traditional Medicare CMMI person.
Excellent. Tell me a little bit more about your time at Common Spirit. I think that the audience is broad. Some people are hearing MSSP and they're like, what is that? Yeah, I hear contracts. I hear you talking about MA plans. I would love to hear about what was your team like at Common Spirit? What were some of the challenges that you faced in that contracting phase, for example? You mentioned the contracting. What does that even look like? The new program. What does Sarah Habib do to tackle it? What does your team look like?
Oh, man. So, Common Spirit is, at least when I was there, organized. I mean, you have the divisions. There's the Texas division, and then there's different regions. And we're in the, Bryan College Station region is, albeit not their biggest region. And so it was a team of like three main people. And we'll get to this later, but the two other people who I worked with at Common Spirit are now the other co founders of APM Connect. And, um, for contracting, I mean, we worked closely with the hospital managed care team on, okay, we want to go do this employer contract with this um this employer, and they have this payer, so we're just going to go into this Blue Cross commercial risk agreement because 50% of those lives are going to be this employer group that we're already
Yeah.
managing.
Define risk for us. I think like some people hear that and are you rolling the dice? Are how do you what is risk broadly for a contract on a group of patients, right? You say that you've got lives under management. It's like you've got a group of patients and you're going to take risk. What does that look like? How do you decide, you know, how much risk you're taking? Just define that for us a little bit and what that process looks like.
Yeah, typically, I mean, risk, I define it as financial risk to the contracting entity, which would be the health system or the ACO. And you're typically going to be in a total cost of care contract where the payer is giving you a benchmark per member per year on based on their risk components. We expect they're going to cost $10,000 a year. Here's your benchmark. And then you do your population health initiatives to make sure that their actual cost of care remains under $10,000. And if it doesn't, then you may owe 50% up to 100% of that difference in the actual versus expected cost of care. And so that's why there's a lot of talk about risk coding and appropriate coding. And a lot of that is because the payers have to have some way to benchmark the patients. And so on the health system or the ACO side, when you're managing to a benchmark, you want to have the most appropriate, accurate picture of your patients. So you're getting credit for the risky patients that are in that pool of lives.
Right. Yeah. And I think this is a nice topic to kind of double down on real quick for folks who are joining. This idea of risk coding. I think if you're not a clinician or maybe even if you are a clinician, like what is that? We get assigned these diagnoses. If you live your life, right, you might have asthma, you might have diabetes, COPD. And each one of those diagnoses mean that you're going to spend a little bit more money on healthcare each year. And for an organization like Sarah's or mine at Duke, we are trying to capture that information because, like Sarah said, there's this benchmark that payers are trying to basically assign to you and say, all right, like this is someone who's going to spend $12,000 a year. And if I don't document the diabetes or the heart failure that you have and then to the payer, you look like a healthy person. And to me, you're only going to spend 8,000. Why did you spend 40,000? And this is kind of just to let everybody kind of wrap their heads around that. That's what the risk coding is. And, yeah, I mean, to your point, there's been some controversy around this, right? Like, is this the best way to capture how sick someone is? And, I think one of my frustrations with value-based care has been that because it's such a tangible way, right, to move the needle on what you're at risk for, if you will, uh, there's been a lot of focus on that. Like, are we coding substantially enough? Are we coding significantly enough? And for me, it's like, that's important because it's a good representation of your patient population, but it doesn't feel like you're changing care for the patient.
Mhm.
Do you want to talk a little bit about that? I mean, it is definitely an important part of the strategy. And I think that organizations that document well do better in these models, but how do you balance where you spend your energy on accurate representation and risk coding, if you will, for patients, documentation integrity versus population health initiatives. And when you do have those population health initiatives, what was your experience when you first came in green out of grad school? Like, I want to do this versus that. What works? What doesn't?
Yeah, I think there is definitely everyone has their own view on
Yeah.
the pros and cons of risk coding, and it is I mean, it's annoying, but from the from this ACO operations perspective, what I'd say is like, well, what's in it for this physician or the specialist? Why is it worth the time? When you get to the population health initiatives and we're looking at the data, everything needs to be risk adjusted. And so you're comparing apples to apples. And so if, in this mandatory ASM model, if you're a cardiologist in the heart failure cohort, you you need to be sure that you're getting credit for the risk of your patients because that directly affects your benchmark, which then directly affects your performance in the contract, which affects your Part B adjustments. But from like a population health initiative perspective, if we're saying, well, we need to work on IPR and patient rehab admits or something,
Hmm.
and we drill down by diagnoses and then even drill down further by physician, we're going to risk adjust all of that. And so we're not, when we go take that data to the physicians, the first question is always, is this risk adjusted? Because my patients are really acute and complex. And so if you're not, the physician's really the only one who can code that for the patient. And so
Yeah.
um, you're doing yourself, I would say, a service if you do accurately code your patients, because you're not going to be the one that they're looking at and going, why are your patients so high cost and your risk score so low? You're doing something
Yeah.
wrong in terms of your management of your population.
Yeah, and I think for physicians, it's so frustrating, right? Because you're like, "I just wanna take care of the patient in front of me," but that data is important, right? And it informs the next specialist who takes care of the patient. So I definitely see a direct line of throughput from clinical documentation integrity to these initiatives. Now, at Baylor Scott& White, the ACO has done really well. You talked about how when you got there, you didn't wanna muck it up,
Mhm.
so to speak. Tell us about how Baylor Scott& White has done, from a shared savings perspective, and what does it look like for you day to day to try to keep that engine going?
We entered MSSP in 2015, but it was upside only and only certain, it wasn't even in the whole medical group because there's multiple tax IDs within the medical group. So it was only a certain region that sort of dipped their toe in the water. And then in 2018, it expanded to all the employed providers. And so we have 120,000, maybe 125,000 lives. And annually, we generate about $110 million in terms of benchmark versus actual expenditures. And then we're in this is called the enhanced track of MSSP. So you get to keep 75% of whatever you generate. So we receive usually about 77 million, and then that's distributed back out to the physicians. Um, Day to day, my role looks a lot like identifying what are the cost drivers of the expense drivers of the contract, and and figuring out initiatives that ultimately, I mean, hopefully cross pollinate across contracts. You're not telling a physician, well, for MSSP, we're really focusing on heart failure, but for this MA contract, we're focusing on X, and this contract we're focusing on. So we all try to work together on the Medicare portfolio team. What are the least common denominator that we're having issues with or performance opportunities in all those, and then it's just working with the various internal stakeholders, who runs care management, who runs quality and gaps in care outreach, and how can we work with marketing to increase our attribution? How do we get patients in to be seen for their annual wellness visits? And it's a lot of strategizing at this point. We've kind of recently restructured how we look at performance of the contracts. We've had some different leadership changes who've come in with a a refreshing perspective and it's very action oriented. And so we have, monthly meetings on where are we at in progressing with these initiatives. Pick the initiatives at the beginning of the year and you have to
Mhm.
progress every month.
That's excellent. So those last like 3 sentences were chock full of just, BBC operator. I think, I don't wanna call it jargon, but like, yeah,
Lingo.
break lingo. Yeah, break it down for me. So you talk about care management team, quality team. It seems like upstream of that, you almost wanna have like a dashboard of here's
Mm,
our MA plans, that we're in risk with. Here's our traditional Medicare. Here's this program, and here's my sorting of costs in each of those buckets. Who does that for you? What does that data pipeline look like? And then you mentioned a few teams, like you talk about moving from data to action. Tell me about the data pipeline, like how you go about assessing where that data even comes from, right? Because it's a little bit of a mystery, I think, to a lot of us. And then what those teams look like. Who's on quality? Who's on care management? Who's on marketing? That's so interesting, right? Like,
mhm.
and define for us that idea of attribution. I know I just threw 6 questions at you, but start with the data. Let's start with the data, and
Yeah.
I'll bring the others.
So the data, well, I think first like basically a contracting grid of what contracts are you in and what are the provisions. And so we have a contracting team who, handles all of the direct to employer contracting, and the managed care team coordinates with them on the payer negotiations for, the major payers. And then I just, for my own sanity, put a grid out of, okay, so I know these are how many lives in this contract and we're at upside only or downside or whatever the thing is. It's just a quality bonus or what have you. So you do need somebody to know, like, well, this is a quality multiplier or this is a quality gate and there's all these kind of things in the contract. But um from a data perspective, it's mostly claims data that you're getting from the payer. And this is going to get a little bit out of my wheelhouse because we have a whole data and analytics
Team.
intelligence team who takes all these files and magically puts them in a cloud. And then you have some reports that you can go in and pull down. And then we
Yeah.
also um, mail them in as a vendor who, they can benchmark you across your peers and nationally and can show with your claims data, here's how you're looking compared to where you should be.
So you look at that grid, and are those files claims? Do they come in like CSV files? What are they? How do they even?
Can tell you I couldn't tell
Yeah.
you for CMS, for MSSP, I know they come in, they're called CCLF
Yep.
something claim line feed files. And then, for the other payers, I couldn't tell you. I
Yeah.
am grateful to have a team that I can just say, "This is the data I need," and they have built out a whole repository of where all that is, and it's in one massive database.
One place for you to see. Yeah, yeah. No, I mean, my experience too has been it can be pretty bespoke from payer to payer. Medicare is a little bit more predictable, but it's so important, right, to be able to compile all of this like you do. So now you're downstream of the data. Tell me about some of the opportunities you guys have identified, and then maybe about those teams and how you
Mhm.
kind of strategize and say, yeah, I'm going to go to my care management team, and this is what care management does. I'm going to educate my physicians on this, get alignment going. To walk us through a little bit of that, if that's okay.
So each, product owner is, responsible for figuring out what are your drivers of your contract and where does the remediation plan need to be. And so we do set that, at the beginning of the year, and we're measuring that monthly. Um, in terms of the downstream, we've sort of restructured it to where we think of these other teams like care management and quality and marketing as if they were external vendors in there. Everybody who is not a product owner is doing work that ultimately supports the product performance.
Mm.
And so it's up to the product owners to then work with your internal vendors, so to speak, to tell them this is what we're seeing in the data and this is what we need to do. And so we need to work together on a strategy and a plan for improving inpatient rehab admits per thousand, or
Yeah.
reducing readmissions, or improving the hypertension quality metric. And so that's kind of how it's structured now, is to have those other teams looked at as more internal vendors, and how do they support the contract. Previously, it was sort of everybody was trying to improve everything. And
Yeah.
and it wasn't so focused on just pick three things, the three top things, and not just everybody go out and
Well, the ocean.
yeah, because that's kind of how we were doing before. There was so many initiatives going on that it was hard to track. If everybody's working on one thing, what is actually making a difference in the improvement, or what wasn't making a difference in the improvement of that measure? If everybody's a bunch of things on it and we're not talking to each other. So um, we've had some new leadership come in and really streamline how we work internally
And
across
over the
departments.
years, what have you seen? And I've heard you kind of reference inpatient home rehab or inpatient rehab admits. Tell me about what you've seen over the years, kind of consistently be an area where you say, like I see a lever there to improve patient outcomes and contain costs. What does that look like? Like if you had to walk us through one initiative that you guys have identified over the years, maybe end to end.
It's always inpatient rehab.
It
It,
is. It really is.
yeah,
Like, yeah.
it was at Common Spirit. It is at Baylor Scott White. I don't know if it's a Texas thing. I'm told it's a
No, it's
Texas
national.
thing. um, that like the inpatient rehab facility per thousand is crazy. Like you just walk to one if you wanted to. Um, and then there's some complicating factors when you're an ACO that's also part of a health system, and that health system has some joint ventures with some inpatient rehabs and with some health agencies. And so how does that we all have to be in agreement that we are trying to provide the best care for the patient. That's also not going to cost them an arm and a leg. I mean, your traditional Medicare, you still have a co-insurance component. You still have your 20% co-insurance. There's no limit on your out-of-pocket if you're traditional Medicare. So there has to be a balance on what's best for the patient, but also not just let's send the most expensive side of care because it's brand new and it just opened up and it's shiny and it's going to cost $20,000 more with the same readmission rate as a skilled nursing facility.
Yeah.
Um,
I think what you're getting at is there's this tension of incentives, right? Like the incentive for the accountable care organization and probably for the health systems to contain costs. There's a limit. You don't want to be skimping on care that patients need because also when you do that, the outcomes are worse. People do end up bouncing back to the hospital. They're unhappy, and that compounds cost, compromises quality. Then on the other end of the spectrum, I think what you're alluding to very politely, right, is we kind of have sometimes these incentives in a fee for service system. Yeah, we've got ownership in that inpatient rehab. Every day the patient stays in that inpatient rehab is revenue for the hospital. And, I think that most of the time we're pretty good stewards of care and of cost, but it's impossible to ignore those tensions. And this is why value based care is really interesting, right? Because it puts those tensions on display and then you have to kind of tackle them and you have a singular focus. You're looking at these different contracts, these risks, you're seeing the outcomes and you say I'm containing costs, I'm improving outcomes ideally. And sometimes those initiatives run counter to what the financial incentives are. So I think it's really interesting. And I, thanks for pointing that out the way that you did. And I think it's hard to navigate, honestly. And I can say that, but you have to find a way, right? Um,
yeah. And
it,
you have
yeah,
to, I think, narrow down. We can't just talk about all patients, all diagnosed who shouldn't be going to inpatient rehab. And so, we're looking at, for example, hip fracture. Um, Ed Lee, he came in 4 months ago. He's a physical therapist by background. He came from Indiana Orthopedic Institute. And so we're looking at hip fracture, and 55% of our hip fracture patients are going to inpatient rehab with a 30-ish% readmission rate. And it's not meaningfully lower than a skilled nursing facility. And so it's sort of like, was that the right decision? Should we have were they even ready to discharge from the hospital? So we're also, working with the health system on capacity initiatives. Everybody's full. And so we need the beds. We've got people holding in the ER. Um, but if you are discharging somebody too early to the wrong side of care and then they're readmitting, it's just a feedback loop. And so we're starting these conversations also with the enterprise office of, we have to find the sweet spot for these patients are appropriate, these patients are not appropriate. And if we do set
Absolutely.
post acute somewhere, we have to hold our post acute accountable. And so we do have a post acute preferred network for the ACO where, I mean, right now there's no inpatient rehabs in that network because we're not trying to encourage use of inpatient rehab that we already overutilize. But for the SNFs and the home healths, we have a team who meets with them, provides data. They have scorecards. We have regional quarterly meetings with them to go over their referral response times in Epic. And like, we need you to accept or deny the referral. We can't just be hanging out there. We need the beds to be turned
Yes.
over. So there is a component of post acute accountability that I think we're going to ramp up even a little bit more in terms of and bring their outcomes into it and not just here's your readmission rate, but again, risk adjust it and show outcomes and 30-day, 90-day spend after that post acute occurrence.
It's one of my favorite, oh, sorry, go ahead.
I was gonna say, I just saw Dr. Logan put in the chat, if I had
Okay.
any successful initiative drive down SNF utilization costs, we're trying to drive up SNF utilization costs. Um, when you look at
And
the
and
Milliman
and you're
benchmarks,
trying go ahead.
yeah. So for the Milliman benchmarks in terms of utilization at admits per thousand, and then they say, poorly managed, loosely managed, just completely unmanaged. For inpatient rehab, we're completely unmanaged in terms of like way overutilizing it. And then for skilled nursing facility, it says we're 100% managed. Like we're not sending anybody to SNF because everybody's going to inpatient rehab. So we're trying to, flip it a little bit and at least be like be on the grid for somewhat managed for inpatient rehab. And so,
Yeah.
yeah, try to balance it out a little bit.
Yeah, this is one of my favorite care episodes. I'm, orthopedic trauma surgeon. We manage a ton of these hip fractures. One of the HAPs I wear at Duke is on the value management committee, and it is so hard for this patient population, I think, because they're sick. People who break their hips, they're Medicare, so they're over 65. They're very frail. And if you look at the data, probably 75 to 80% of these patients go to either a skilled nursing facility or inpatient rehab. Sounds like you guys have a really high proportion in inpatient rehab. Um, for us, we're trying to drive down SNF utilization and we're trying to decrease the length of stay in the skilled nursing facility once the patient
Mm.
leaves the hospital. And this is a great, probably, point in the episode to talk about the transforming episode accountability model. This is a new mandatory model, affects 729 hospitals throughout the country. It is downside risk, right? It is dual-sided risk once you get to year 2 through 5 of this program, up to 20% on these episodes of care, and hip fracture is one of those episodes. I saw Mike Logan just commented, "It's ortho's fault." It is the bonehead's fault. Yes, yes. 3 of the 5 care episodes are orthopedic. On the hip fracture bundle, we've looked at where the cost is concentrated, and, these aren't like other patients where you can optimize them preoperatively. Your opportunities here are getting to the OR quickly, right? And we know that correlates with decreased mortality. So we track patients who get to the operating room in under 48 hours, ideally in under 24 hours. So like the clock starts ticking when they get in the hospital. But I think the big challenge is a lot of these patients, they're going to go to a skilled nursing facility. Can we get some of them to actually go home? Like, that's what we're trying to do, Mike, is we're saying, "Hey, you're 70, but you're like a silver surfer. You broke your
Yeah.
hip, while, like, climbing a ladder, in your barn. Let's get you home with home health services for a defined period of time, and you're gonna do okay." That's what we're trying to do. The other thing we're trying to do is for patients who do go to a skilled nursing facility, like, it's kind of a black box, and I'd be interested in your thoughts, like, from an operator's perspective. We have some control when they're in the hospital. Like, when they leave, it is very hard for us to track down who to call at the skilled nursing facility, like, unless they're a Duke-affiliated facility. I don't know if they're still there at 7 days, at 21 days. I've started doing telephone visits for my hip fracture patients at 2 weeks. I close them with absorbable sutures so they don't have to come in person. And I try on the call to like speak to the patient or their care proxy and ask, have you been to the ED or been readmitted at somewhere other than Duke? If I don't see the
Mhm.
chart. Are you still in a skilled nursing facility? And if so, what's the plan for getting you out of there? And, I think like I've just been really surprised at how hard it is to get that information and to drive management in those settings that are outside of, the facilities that you control. So that's our approach, but we haven't had a lot of success. The very first techie surgeon podcast that we had was an interview with Alex Crespo, who's an orthopedic trauma surgeon in Chicago, and he's got this the Road Home program, and they've been marginally successful at getting patients who have hip fractures home. But what do you do uh, to get visibility? I'm really interested in that visibility in the post-acute setting. Like, how are you engaging with the inpatient rehab or the skilled nursing facility, if at all? And
Yep.
what do you guys have in place to, communicate between the providers there and here and align to get the patients home safely once they've been there for 5 days, 12 days, et cetera?
We have so under the care management umbrella, there is a 6 to 8 person team of nurses that are the post acute care nurses. And so if it is an ACO patient, so not just MSSP, but that's a lot of the post acute, but any of the MA contracts we have too. Um, if that patient is discharged and they go to one of our ACO preferred SNFs, which we have 67 SNFs in our network, then they're following that patient the entire time they're at the SNF, because one of the requirements to be in our preferred network of SNFs is that you have to give us access to your EMR, read only
Mm.
access to your EMR.
So are they on a different EMR, most of these SNFs? You guys are on Epic?
Epic, yeah. And so
What are they?
something else, point
Okay.
click care and something else. I don't remember, but they have to. So there's, I think, 6 nurses who they divide out those. They each maybe have 11 sniffs that they cover, and so maybe it's 11 different logins. But um,
That's
they,
brutal. Do you guys hear that? You guys heard that? 11 different logins. I
yeah,
know there's some startup folks on the on the chat.
yeah. Um, and so they'll open up a Compass Rose, which is like a care management documentation in Epic, and so the physician could see, okay, there is a nurse following this patient while they're at the SNF facility, and they're checking that patient's chart every day in the SNF, and they also have weekly interdisciplinary team calls with the SNF on what's the expected discharge date. The expectation is that they have an expected discharge date within the first 7 days that they're there, and our goal is that 28 days. They shouldn't be there longer than 20. The SNF
Yeah.
should have an average of 28 days, and so we get it, some are more, some are less. And then we also have a return to acute percentage goal that our team, the post acute operations team, is in their scorecards going over that data with them. But I mean, that is something that was totally foreign to me when I started at Baylor. I was like, whoa, that's crazy that we actually have nurses who can look at their chart in these outside facilities, and they're doing a med rec. They're calling the SNF and saying, this was ordered at the hospital and it's not on your order list, at the preventing readmissions because of, just human error. And they've been really, really successful in terms of the patients that they follow at the preferred SNFs versus the ones that we don't have visibility into because they're not in our network. But our higher volume SNFs, we try to get in our network for that very reason.
Yeah, that makes good sense. Yeah, this is a tough workflow to crack, and we've definitely tried in various settings, both at Duke and at Revel AI. We've got this feature called Care Huddle. It lets the clinicians who are part of a care team like communicate in one little huddle, but it's still really hard because you have to identify that person if they're not on the same instance of the EMR, and that person might change. So
Mm-hmm.
it's not an easy problem to solve, but it sounds like you guys are, really brute force making
We're
it
making
happen.
it work.
So we talked a little bit about team, or I did. I would love to hear your perspective on these models, right? You talked about products, and it kind of feels like, you correct me if I'm wrong, but there's all these new Medicare products that maybe just sprung out. Team, transferring episode accountability model, ambulatory specialty model. We haven't heard all about lead yet. I don't
Mhm.
know if that will impact you. We don't know yet, right?
Mhm.
And now there's access, and that's like a little different. I would love to hear you kind of walk us through how you're thinking about these programs one by one. And maybe you can introduce APM Connect, which I think is a
Mhm.
really interesting organization that you founded. You're a founder too. Uh, so, yeah, walk us through those three programs, kind of what your approach is to them, and then maybe introduce us to APM Connect.
So team is started 1/1/26. It's the 5 surgical bundles. You were either told you're in it or you're not, by CMS. So there's, 700 something hospitals. And the general, idea or vibe seems to be like, I'm not really gonna do anything year 1 because it's upside only. There's still, I think, a lot of hospitals who are not aware that they are in it, or if they are aware that they're in it, then they're not that engaged. And I would say from a Baylor perspective, so we had some hospitals that were in CJR, and there was CMS said, you have a one-time opportunity. If you were in CJR, you can voluntarily opt in to team, but nobody else can self-select and go into team because, they want to mitigate that self-selection bias. And so Baylor ran the numbers and was like, yeah, we're not going to opt in. I mean, we weren't going to lose a ton of money, but it was going to be, I think it
Or,
was more or less going to be break even or
yeah,
very, very small upside and for a lot of work. And it was only going to be, a couple of hospitals, and we didn't really want to do something that couldn't be system wide. And so I would say for the hospitals that are in team, or you don't know you're in team, but you're in it and you're not taking it seriously, the fact that there were only 4 hospitals that voluntarily opted in should tell you it's not a windfall of cash, or there would have been a lot more hospitals who opted in. So I would say start being actively involved
yeah.
in the and if your regional peers are paying attention and you're not, then that affects your benchmark. You're competing against the hospitals in your region. You have a regional benchmark. So, that's my take on team. I think it's undervalued in terms of the
I think people are totally ignoring it, just like you said. So, and I spoke to a lot of folks about Team back when it was first announced in 2024. A lot of wait and see, I
Mhm.
don't know, we're going to figure it out later. And it's now that I think that people are like, wait, where's this portal I got to log into?
Yeah.
What I got to get the patient's got to follow up with their PCP within 30 days. And to your point, I mean, this is a program where you're getting compared to your peers, and it can get pretty ugly pretty quickly on these care episodes. If you're managing 400 to 600 of these patients, it could be millions of dollars on the line. I'm going to see if I can share my screen here. For folks who are interested, first off, this is all available online. You can find the team participant list, and look up whether your hospital was selected. There is some data out there around some of the benchmarks. And for folks who want to go to revelaiteam.com, we've got the target prices up, and it's all over the place. I mean, I think that there are some hospitals from the data we've seen that could really lose a lot of money in this bundle. And then there are others that are going to do okay. There's not that many, though. Honestly, it skews towards people losing money. Um, so, how are you and APM Connect approaching this bundle? How are you helping hospitals sort of find their way, um, to apply value-based care principles to these surgical episodes for many of these hospitals for the first time? That's something that I noticed. I don't know if you noticed this too. Like, it doesn't seem like it was random when they selected these
No.
hospitals. It is a lot of hospitals that have never done this kind of work before. And it's just like this idea of care management, of patient-reported outcome measures is going to be foreign to them. How is APM Connect helping, and how can people get in touch with APM Connect to learn more?
CMS, I don't believe I'm making this up. Believe in their rule, they said that when they were selecting team sites, they purposely were going to oversample hospitals that had never been in value-based care because I think that they're at the point CMS is sort of like, we're going to drag you in to value-based care, kicking and screaming. At some
Yeah.
point, we're not going to do these self-selection models anymore. And so it's true. There's a lot of hospitals who are, probably like, well, we've never done this before, so we'll just wait and see the first year how it goes. But by the time you figure out how it went, you're going to be in downside risk.
Yep.
So, APM Connect is I co-founded it with Rayanne Davis and Casey Hilbin. We work together at Common Spirit, and it's it's meant to be it's a free community for anybody in a mandatory model. And right now, it's focused on team and ASM because we have those participant lists, and we've been trying to outreach to some of these smaller hospitals who probably have no idea, but it's very hard to find the person who would
Yeah.
be responsible for bundled payments at a small hospital. But if you work at one of those, or if you know somebody who does, or even if you just want to join for the heck of it, and you can join for free at apmconnect.com. And we have different things for team and ASM, but learning resources, there's posts you can post, and we have webinars, and either we'll present on something or a hospital will present a best practice on, like Intermountain Health presented on how they manage their post-acute network and how they're doing that for team. I presented a little bit on ASM. We brought in David Pittman, who used to be the policy expert at NACOs. He's now got his own independent policy company. So yeah, I mean, we're always looking for physicians, ACO leaders, and hospital executives to join and just talk to one another. And we don't have to gatekeep secrets. There's no membership fee that you have to. Well, how do I justify a $500 membership fee? There's no membership fee if you're one of these
Yeah.
clinicians.
I love that you're doing this. Because I agree with you. Having tried to reach out to those hospitals, they're not really aware of this model, and I think that this is going to be a great resource for people who are trying to just learn also about these models, because I think that they are going to spread. That's been the signal from CMS, right? We're seeing more accountable care, not less, and yeah, there's no fee to sign up. You guys have already put out some really great resources. I think they'll only get better. Now there is a proportion of hospitals you've been able to get in touch with that have joined. I think I saw how many of the 729.
I think about 200.
Wow, that's actually more than the last time we talked. That's great.
Yeah.
That's great. So folks, if you haven't heard about this organization, apmconnect.com, Sarah co-founded this, and I already have found some really great resources here. So definitely sign up. I think that this is the kind of thing that we need is just more information being shared about these mandatory models to demystify them. Um, so we talked a little bit about team. I do think there's 729 hospitals. It's going to be a great resource for them to try to learn about this. Tell us about ASM. That's also a little bit different. It's mandatory and it's not affecting hospitals. Tell us a little bit more about ASM.
ASM is it's the first time, at least that when I've been in value-based care, that there has been an NPI specific participation model. Ambulatory specialty model is CMS's way that they're going to try to manage heart failure costs and low back pain costs. And so there's a cardiology cohort for heart failure, and then there's a whole different bunch of specialty types that could be eligible for the low back pain cohort. And they are going to measure you on quality and cost, and then based on your score compared to your peers that are in that same cohort will determine whether or not you get a positive or negative adjustment to your Part B fee schedule. And they explicitly stated in the rule that they are trying to sort of do this market competition type of thing.
Mhm.
Um, you know, this Dr. Smith who treats heart failure 5 miles away from Dr. Jones who treats heart failure are going to compete against each other for the money. And they're
Yeah.
going to show that they are more efficient than the other, or that they do have a higher quality. Um, and so but the thing is, it it is a big deal. It's still a big deal. But at Baylor, I thought we were going to have 200 to 400 physicians.
Right. Not
And
not the case, huh?
no, so the NPI list came out a couple of weeks ago, and it was like wait, why do we only have 51 physicians on this list?
Yeah,
And it used to be the consensus nationally. I mean, we had a forum, APM Connect today, on ASM, and everybody's like, yeah, we have 6 people on this list.
yeah.
So we have to spin up quality reporting for 6 providers,
It's
or
like prohibitive. Like,
negative assessment.
yeah,
So I think they sort of shot themselves in the foot, because I thought when it came out, I thought this is a huge deal. It's physicians competing against each other, and it's not just sort of some nebulous idea about total cost of care and,
right.
per member per year. It's like, we're going to look at this heart failure episode. How did you do compared to your peers? But then they really just put nobody on that list almost. And so the cost of doing nothing versus the cost you're going to spend to meet the requirements is, I mean, that's something
Is
I think they got
it's
to figure out.
Totally, totally agree. So, we put together this dashboard. This is all public data. You can go to the so and then we're gonna get into AI in the last like 5-10 minutes. We used some of the large language models to pull CMS data from the ambulatory specialty model database. We cross-referenced it to people's Part B claims from 2024, I want to say, and it's 9% penalty in the first couple of years. That goes up to 10%, 11%, 12% as the year goes on. The average penalty per provider is about $40,000. Like that's not great. Like I don't want to lose $40,000, but how much does it cost to bring in a vendor that's going to reach out to your patients and do PCP collaborative agreements? Like at least a fraction of that, right? And it does become very hard. Now, there are some organizations that have got a lot of clinicians selected. And again, this is all public data here. Um, but so some of these organizations I think are going to have to mobilize to figure out how to avoid losing a few $1,000,000. But others are going to struggle. And there's a ton of these, the folks selected. When I look at the organization breakdown, like one provider in the
Yeah.
organization, it's just physicians all over the country that have been selected, and I think it's gonna to your point, they may have shot themselves in the foot a little bit because it's gonna be hard to drive uptake. Now, this is replacing MIPS for those physicians. There's no opt-out or exemption for if you've been selected for this model, so you gotta figure something out. And I think that APM Connect has got great resources around this. We did try to, on techiepolicy.com, put together all of the quality performance measures, but half of this is related to cost. So I don't know. I think it's going to be interesting to see how it gets rolled out. I talked to one practice and they were like, "We think our EHR is going to take care of it." I don't know that that's going to be the case. I don't think so. I think that they really are trying to drive behavior change with this. So I don't know. Either a lot of clinicians are going to lose their shirts, or and people are going to be upset, or I don't know. Maybe people will band together and some low cost options will come out to try to collaborate, get this care going. We'll see.
Yeah. And one of the other things that CMS said in the rule was, well, we want, these physicians who are employed by these large health systems who have been able to escape all these burdens of programs. We want them to have to feel the same pain as these
Right.
independent
Participate.
physicians. But that's not going to be the case if, Baylor Scott White is going to figure it out for the 51
Yeah.
providers who are selected. And somebody's going to pay for the ECQM vendor, and it's even going to be the physician.
No.
So what we're doing, this was going to be the strategy anyway, even if there were 200 physicians selected, but it's 51. We'll say, all the employed physicians are in our MSSP. And so we're just going to have a heart failure strategy and a low back pain strategy. And 2026 is the year, the testing year. And we're going to start deploying that this year, so that in 2027, the initiatives that the ACO is rolling out and working with the medical group on in relation to heart failure and low back pain will start paying dividends in 2027 and beyond. And we still can go to the regional CMOs and say, you do have physicians in this model, so you do have to do this now. And so
Yeah.
we're just going to sort of create our own shadow bundle and build the specs internally and just say, we're going to have our own, ASM as the Baylor Scott White MSSP.
Yeah, I mean, I think that's a fantastic approach. And look, the reason that these conditions got selected is because they produce big problems for patients and for clinicians, and it is a unique opportunity, I think, to try to get people, appropriate GDMT, to maybe reduce the number of MRIs and high risk opioid medications we prescribe to low back pain patients. So I think it's great that you're driving that, and as Baylor Scott White does that, that means that all the other clinicians in that region, they got to do something, because otherwise, you're gonna, not intentionally, right, but kind of clean their clock on the
Yeah, you
savings.
run the risk of like, well, what are my competitors doing? Because if they're doing something and I'm not doing something, that's not good.
Exactly. Yeah. So, Sarah, we got about 10 minutes left. Nine. I got to ask you, in your dream world as a VBC operator, where do you see AI making a difference? And where do you see it really not making a difference? Like, have you been approached by vendors? I'm sure, like, your inbox just blows up with somebody trying to sell you a new shiny AI tool. I thought you said something interesting when me and Sarah were exchanging emails, and she said, I don't spend a lot of my day thinking about AI. And you guys save $107 million a year. So where is AI going to, in your opinion, make a difference in accountable care? And where are people misguided and wasting their time developing shiny tools when they should be focusing on something else?
What would make a big difference, and I know there are tools out there that I've seen some demos, and I think Epic has their own now, is around appropriate discharge disposition. Like, we have the issue with inpatient rehab. And so there are tools that can say, okay, well, this patient with this characteristics and these comorbidities in the hospital should go to inpatient rehab, or this kind of patient is going to have more success at skilled nursing facility. And here, what's accurate this percent of the time, and here's the readmission rate. If we can implement that, which I think is on the roadmap, I think the Epic tool is called like Galaxy or something,
A lot of
where
data. Yeah.
it's supposed to say, which, I mean, it depends, I guess, on the accuracy of the inputs into the model, but it would be helpful to say, if someone goes to say this patient discharged to inpatient rehab is the recommendation, if it could say, well, hey, actually, this is a hip fracture patient that historically is going to readmit 38% of the time. If they went to
Hmm.
setting of care, or if they stayed one day longer, this is the expected outcome. That sounds like magic to me. If that can be populated, that would be really helpful, um, to make that connection between value-based care and the hospital case manager's like bedside of, oh, actually, this is what's going to happen if I do this. And
Hmm.
this patient's next 90 days look like if he goes to this setting. Um, the other thing that would be helpful, we have a home health problem a little bit as well. Some patients are on for 2 years, and it's very difficult. Even when I'm doing chart reviews, I'm like, if I have time to sit down and do a chart review that's taking me this long to understand, there's no way the physician is taking this
No, we're
time
not.
to do
Yeah.
this. Because I even went through it and I was like, I can't do this. I can't understand what's going on. And it's, 10 pages of all caps, wall to wall text of what's going on with the patient and their goals of care and what do they need. And now they don't need this anymore. And this appointment was canceled. And it's just research, research, research. And they can batch sign them electronically. And I
Hmm.
think that's not the physician fault. They don't have the time to do it. And you don't want to be the person who denies the patient care that maybe they like getting, and maybe it's a social visit.
Yeah.
And there needs to be some type of tool rather than a pre-review, like an actual nurse or social worker who is spending time reviewing it and saying, okay, here's the synopsis of what's going on. Then send that to the physician and they can make the decision. If there was some way to combine all this data on their, okay, they've been on for 200 days, they've had this many
Hmm.
visits, they buried in the paperwork, it says they live in assisted living and their daughter comes over 4 times a week. Do we need this then? I mean, people
Yeah.
had
Yeah.
0 ED visits in 12 months, but they've been on home health for 2 years. I think they're supported, like, I think we're good. And
Yeah.
there's just no one who has time to do that, and it's a lot I don't want to say easier, but you don't want to be the person who's like, I'm gonna discharge her from home health, and
It
then
is
they
right.
recommend it.
Well, it is easier, right? It's like so hard when you're balancing so many things as a physician. You get this inbox, especially primary care, and it's to your point, 40 of these, and you're like, oh, like I hope that a lot of these are appropriately prescribed. You kind of look through them. Uh, the good news is that I do think that AI is really good at that, at parsing through documentation and extracting the criteria. And people just haven't heard that use case before. So maybe now that you've been on the Techie Surgeon, I see my co-founder on here. He hopefully will spin that up as a new module in Revel AI or something, or maybe Epic will. We'll see. But yeah, I think that you're right. Like that's a great application, right? Like this administrative burden. How do your care managers do their outreach right now? Is it all telephonic, like just on the
There,
phone? And
yeah, there's telephonic, and I think there is some text capability now because Baylor Scott White, they have a very robust app, and there's a discharge companion portion of the app where you can check in with the patient via the app. But I think a lot of it is still telephone.
yeah, yeah. How about in your personal life? How are you using AI these days, if at all? Do you talk to ChatGPT a little bit? Is that it?
I try not to for things I'm like, you can figure this out. And I'm like, don't be the reason we need to build a data centers because you need to like chat GPT
Oh,
something
good.
you can
Yeah.
figure out yourself. Um, so no, to be honest, I don't use AI. And I see your posts. I flagged one of your posts and I was like, I have to figure out how to do this. Um, like, you know, making your own slide, like not spending two
Yeah.
hours making a slide deck.
Yes.
And so I need to spend 2 hours learning how to not take 2 hours to do the slide deck.
We're gonna teach you on the Techie Surgeon. That's our
Yeah.
goal, Sarah, okay? And actually, like, so right before you jumped on, one thing I did, I can't promise that every little bit of this is accurate, but I popped this just into Claude, okay? This isn't a fancy secondary app, and, we had all the MSSP data pulled from Baylor Scott and White, and, I'll send this link over to you, but I think, like, this is just, like these are just use cases, right? Like, you can very
Yeah.
quickly and easily, like, kind of pull some of this information from like these CMS public data websites, and then make decisions. Um, awesome.
Yeah,
If
I need a
if there's
tutoring
one thing,
session.
if there's one thing you think AI should never do, what is it?
Oh,
Or do you think it already does too much? I don't know.
I saw something about like there's an AI school type of thing that you can put your kids in elementary school and it's like all about AI. I was like, please don't. No, we don't need this. Um, I have 3 young kids and I'm like, no, please stay off of technology as long as
Yeah.
possible. Yeah, that sort of like gave me the heebie jeebies when I saw there's like, oh, you could put them in this AI focused school. I thought, let's not do that.
Yeah. No, thank you. Yeah, I got 2 young kids. Michael Logan, who's in the chat, was, on a week ago or a couple weeks ago, and, yeah, he's got kids. He's a minivan guy. I heard you're a minivan
But
mom.
honestly, get the, you know, touring package. You need the DVD player.
I really want one of these minivan companies to sponsor the Techie Surgeon,
Yeah.
podcast at this point.
Wanda, are you out here?
Awesome. Yes, it's a minivan crew. Yes, yes, we got somebody saying that in the chat. Hey,
That's
anything
funny.
that you wanna say in the last minute here? How can people get in touch with you? What anything else you wanna say as we wrap up here in the last couple minutes?
I mean, I would say if you are gonna be the physician in value-based care that's engaged, you're gonna have a best friend in the ACO. We are always looking for this physician gets it. They're engaged, and all of our ideas are gonna be filtered through that person before we go
Mhm.
take it to this broad group. So, um, if you wanna be the person who is at the table, like, "This is a bad idea, this is a good idea, this is what I wanna work on," you'll have a very easy time finding somebody in an ACO who's like, "Yes, we want a physician champion." And then, yeah, I mean, to get in touch with me, I'm on LinkedIn, Sarah Habeeb. I'm on apmconnect.com. And yeah, that's about it. I don't have my own Substack, so maybe one day.
Yeah, we're gonna convince you to write one for sure. That's awesome, Sarah. We really appreciate you coming. I love reading the comments here. So AI should never replace human judgment. I agree 100% with that statement too. We should always be using human judgment and discernment. These are tools, right? Augmented intelligence, not artificial intelligence, really. Sarah, we really appreciate you coming on. We learned so much. I hope that you'll come back again and tell us how
Yeah.
things are going at APM Connect, how the team hospitals are responding to this, the other physician champions that you find. And yeah, thank you so much. We really appreciate it.
Yeah. Thank you. It was fun.
All right. See you again
Bye.
soon.